Welcome to Mostly True Psychiatry with me, Dr. Mellon. We're going to start working on our note writing like a boss. So, again, this is in the brain, but actually today I'm teaching off a Dynalist in the next few videos. So, you can search for note writing like a boss, type in Dynalist, D-Y-N-A-L-I-S-T, web presentation, something. I'm going to click on the icon with the brain, brings up the website. Last time we went over general information for the history and physical, the initial evaluation, and now we're going to start going through the check boxes. Okay. HPI is typically the first section. So what do you think should be in there? Most commonly, it's a data dump section. They treat it like HPI says subjective, which is the first third-ish of the note, and they just data dump. It's hard to look back at. They try to cover their base points, and they have no intention of writing detailed notes for follow-ups and keeping information. So super common. Super bad practice, but that's what they do. I typically, my section just looks like this. It's CC, Chief Complaint. You should put one of three things in there. Don't get caught up on it. Insurance just wants you to write consultation, initial evaluation, follow-up, done. That's good enough. You don't need to do anything like depression or here for whatever. Source of information is the EMR, patient, and whoever else, family, friends, parents. You can put legal disclaimers here. I do right now. Should just be at the bottom. I should quit doing it. You don't want to write things twice, right? So don't. So past psychiatric history. This really separates people again on how they do notes. So some people will, kind of like the HPI, they treat this as a data dump. They'll just list every diagnosis they've had, all the drugs they've been in, they've had. It'll put their suicide attempts, inpatient hospitalizations. It's kind of these things. So it's their psychiatric history from other doctors and other visits. This is where, I'm going to argue biopsychosocial should be the thing that has this information. A lot of this doesn't need to be here. So you can just put suicide attempt, January 15, 2012, or you can put, actual biopsychosocial. You can write it when they were in high school and say, well, patient was in high school, started doing drugs, parents divorced 2 years earlier, had blood pressure medication from mom, took it, ended up in ICU for a week. Patient diagnosed with major depression starting at this point. Something in the biopsychosocial is more of a story and not just suicide attempt at this point. Because sometimes that's not a good piece of information, just suicide attempt or this thing. It could be they got a diagnosis and it was actually from a state hospital, state-run facility, or like insurance required it. One of those two where they require them to put a diagnosis just because that's how they get paid. It won't be covered otherwise. So like a place that I work at right now, everybody gets one of like 4 diagnoses. Your schizophrenia, schizoaffective disorder, bipolar mood disorder, or your major depressive disorder. Basically 100%, or the state won't pay for it. Is that true? Heck no. So sometimes their diagnoses, just because you list it here, it's not even true. It's just, they're bipolar schizophrenic. It's like, well, you can't have both. If that's the case, you're actually schizoaffective disorder, bipolar type. Family history. This is going to be a controversial topic, maybe. So what's supposed to be in here is family diagnosis. So like mom has bipolar mood disorder, dad has schizophrenia, brother has alcohol use, use disorder, whatever. I think this is lazy, bad, improper. Psychiatry should stop doing this. Most epidemiology is wrong that uses this information, kind of thing. So do you believe that when you talk to a general practitioner, another medical doctor, that if they write down bipolar mood disorder, do you assume that doctor is correct as a psychiatrist? Do you just write their diagnosis, they give them to you to start treating, because they wrote it? Probably not. So why would you expect a layman to know the right diagnosis? Or they tell you it's a diagnosis and it was from one of those state facilities, so they got the big 4. Or they don't like this person. Why would, so it's kind of a way to make this really apparent. So If someone says their mom has bipolar mood disorder, do you immediately just start happily writing down patient being given preliminary diagnosis of bipolar mood disorder type 1, most current episode depression, as evidenced by severe depression, delusions of paranoia, reduced need for sleep, and a patient with a family history of bipolar mood disorder? Look, check, 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 check. Bam, diagnosis, genius. I checked them all. Or is the reality they arrived by police, they've been on meth for the last couple of weeks, been using for years, their girlfriend recently dumped them and is pregnant with their baby, and they tried to kill themselves? Are they both correct? Is one of them correct? So family history does not, I find, I don't trust the patient knows the right diagnosis. I have a hard time accepting non-psychiatrists have the right diagnosis. So I don't put any stock in it. I think it can lead to a lot of bad outcomes because you won't have correct information. So past medical history, we'll move on. That's enough of that. So this is a part that new residents are going to struggle with because they end up writing a note inside of a note. They're like, well, I read all the medical doctors, primary team stuff, and then they're trying to crush all that into their own note. Really, it's just you want to know the main issues that they have. What are they have diabetes, hypertension, hyperlipidemia, whatever, and really acutely relevant information. They had a CVA in 2018. They're on warfarin, or whatever, and you're putting it there for the initial note. It's going to have more information. It'll have as much information as you kind of need for your own treatment modalities, and then you'll take some of that information and pull it down to actually put in your assessment, as we'll talk about in a later video when we get there. So it'll be kind of written in detail a little bit once, but after that you're just trying to carry information forwards that's actually in your notes. It's pretty common to have something generic you can just cut paste in real quick so that you have a rollout or a negative finding, so like patient denied history of these things. Or if they do, then you can put, diagnoses and then list them out. Hypertension, DM2, A1C is, 9.8, etc. I mean, it's totally fine. I do like listing out the current medications. I don't typically put the actual dose because I don't care most of the time. I mean, I can try to pretend I do, but I don't. It's just extra keystrokes. You can just say C H&P or C note by Dr. So-and-so, and you don't really need to do it yourself. It's just you need to have reviewed it and look for the things that you care about. And when you don't know, you're going to overwrite. That's just the nature of the beast. So next we can do, I'm going to skip the biopsychosocial because we have a bit of time. I'm going to go through the next several sections, and then we'll do a video on biopsychosocial and a video on assessment and legal. So the substance use history, it's however you want to do it. Everybody, or the most common, people put illicit recreational drugs, kind of list them out or do whatever they need to do. And then they'll do tobacco, alcohol. I often don't put benzodiazepines as a separate one because I care. Opiates, if you're in a place where opiates are a problem, maybe do that. Remember, be appropriate. So if a person is, had alcohol or had the drugs, you want to know, when did they start? How frequent? Last use? Have they ever tried inpatient or rehab? Or are they on AA or Narcotics Anonymous, NA? These kind of things. Why are they not? Because you might need to do a lot of patient education or trying to push that, this is a long-term problem. It's not going to be a short-term issue, even if they've been sober for a year or two. All right. And then mental status exam. So this should be the most important part. That's how I wrote this originally, but after, a couple years later, it's sorta. So a mental status exam should be your psychiatric geniusness of how they're presenting and looking and doing, right? A lot of patients is depression, anxiety. It doesn't mean anything. Schizophrenia means a lot. Autism, it means a lot. Delirium, dementia means a lot. That kind of thing. So let's see. Yeah, we already covered that. So standard format kind of set up. It's arbitrary. There's no right answer, first and foremost. Typically, a lot of psychiatrists try to group as many things as they can together, so it has as few as sections as possible, and they have it as a cut, paste, vomit list. So appearance, behavior, speech, often one big thing. If one of them's super important, you could break speech apart if it's really, really relevant. But it's basically kind of how they're acting, doing, talking. And you would just keep it. And then if they're severely depressed, or they were catatonia type problems, and it's problems with anhedonia, schizophrenia, they're not taking care of themselves. You might want to put, instead of grooming and hygiene, you just highlight it, instead of appropriate, and you just poor, right? Has a foul odor, whatever. If their speech is like super minimal, no eye contact, very concrete, autism kind of thing for some patients with autism, then you need to put it there. You need to make it's relevant. Mood, affect, you're supposed to know that mood is what they say, which is fine or good, right? It's always one of those two. That's what everybody says, so it's kind of dumb. And then affect is, tearful, euthymic, labile, towards agitation, depending on topic of discussion, something like that. Sensorium is just a place to, you don't care, it's alert and oriented times 4. You don't care unless you're just trying to make it obvious that maybe they don't have capacity right now because they're delirious, they're floridly psychotic, that kind of thing. And then you would be putting that information in. Thought process content is where you're doing your, basically, do they have psychosis, schizophrenia kind of thing. So that's your AVH, audiovisual hallucinations, your perceptual disturbances, delusions, or kind of what they are. And then I usually just put suicide screen below it on my H&P, and then it has its own section if you look at the follow-up note. When I gave them, there's a link that I'll put again below for a couple of these videos where it gives you a template for these. And so all my follow-ups, it's higher up, it's above the MSC for the suicide screening. But it's just something you should always do. It's important in our field. So labs and imaging. Again, you're not trying to rewrite your medical team's note. You're just putting kind of what's relevant to you. If you didn't write it, assume that you evaluated it and that it was fine. You don't want to see a bunch of labs that you don't want to cut paste forward. So CBC, I'm putting if they're having problems with anemia, their MCV is 108 and they're alcoholics or something, and then that's relevant. CMP, I mostly, if they're on antipsychotics or lithium or something, I'm looking for creatinine, kidney function, I'm looking for liver function, AST/ALT. Lipid panel, antipsychotics, TSH as supposed to, if it's really, really low, it's going to cause psychiatric symptoms. If it's really high, it'll cause psychiatric symptoms. So you look at it. Free T4 when you're trying to figure out the reasoning for it. A1C for, and when they're on antipsychotics, really, that's the only reason for that drug, or for that lab. Imaging, you're just putting if they have head imaging or broken bones, they're complaining of pain. I guess that's relevant, but you're just minimal. You can cut and paste for whatever the lab technician said. Just cut and paste it. Don't sit there and struggle over it, because mostly you're not going to follow this information going forward. It's just certain labs you care about. Physical review of symptoms. So ask questions you actually plan to respond to. So toe fungus, I don't care. If they have pain, maybe I do care. And there's you're going to do the whole SNRI venlafaxine thing, or you're going to do duloxetine, or you're going to do gabapentin or something as part of, I'm going to treat neuropathic pain plus my anxiety, depression, or whatever. People will usually just have a cut paste list, and you just add stuff where it's relevant. If they have abdominal pain, you have to put it. So if they have cyclical vomiting syndrome or something going on. I'm going to skip the assessment for now because we're going to do biopsychosocial and assessment, I think, for the next video. Legal, I would just encourage you to do this at the bottom. I'll give you some options with this one where you can cut and paste legal, just generics examples, as well as you can get more specific ones, like if they're on TCAs, you might want to do one for serotonin syndrome. If they're on lamotrigine, you might want to just put one specific to Stevens-Johnson syndrome, that kind of thing. So I hope that was helpful. It's been mostly True Psychiatry. I'll see you again soon.